Welcome, YouTube. It's time for the live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. So, wow, we completed chapter 31 on the last reading, right? And now it's been drizzling, getting some rain. We need it. We can always use it. We want to give thanks, highest heart love, to our friends and family. We are here. So now we're moving into chapter 32, Chronic Obstructive Pulmonary Disease. Page 470. Peace, everyone. Happy Friday. Love to our friends and family. Yeah. Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, COPD, has become the nation's fastest growing healthcare problem. Bronchitis, emphysema, and asthma have increased over 200% as a cause of death in the past 25 years, and COPD has become the second largest disease entity receiving Social Security disability. The American Lung Association estimates that over 450,000 new COPD patients are seen each year, and there may be as many as 15 million sufferers in the United States. In addition to genetic predisposition and many unknown factors, three realities of our modern environment guarantee the continued rise of chronic obstructive pulmonary disease as a healthcare problem. 1. Cigarette smoking has been shown to be a contributing factor in the early development and severity of COPD. In the female population, this is reflected in the increased incidence of COPD in the female population because of the increasing duration of their heavy cigarette smoking. Despite the clear link between cigarette smoking and pulmonary disease, there is little indication that the younger generation is heeding the warning. Wow. Whew. 2. Air pollution plays a role in the symptomatology and progression of COPD as the particulate and noxious gases components of air in urban areas increase. The problem of chronic obstructive pulmonary disease becomes more apparent. 3. Modern medicine has created an ever-increasing geriatric population. As people live longer, the problem of COPD becomes a greater sociologic and medical problem. Chronic obstructive pulmonary disease is neither of infrequent occurrence nor of small consequence to our society. The costs for treating this disease entity overwhelmingly at present, the American taxpayer spends hundreds of millions of dollars on the care of patients with COPD. The incidence, sociologic impact, and expense make it imperative that the discipline of respiratory care address itself to the treatment of COPD patients. Unfortunately, most of the efforts have been focused on acute hospital care, while little energy has been applied to treatment of the chronic state. Peace, highest heart, love. Welcome. Thank you for reading with us. Peace, YouTube, to the peaceful and quiet part of YouTube where we read books and learn from masters. So, I'm Master Fitness Trainer Uriel Neville Riley. Thank you so much for being here and reading with us. So beautiful and peaceful. Thank you for being in this part of YouTube where it is peaceful. It's just a wonderful thing to be able to channel. Um, I'm very honored to be able to bring it to you as well. All right. Obstructive pulmonary disease. Page 471. Obstructive pulmonary disease has been classically defined as an increased total lung capacity in conjunction with decreased expiratory flow rates. Since the power to inspire is actively provided by the muscles of ventilation, it is much easier to overcome resistance during inhalation than during the passive process of exhalation, especially during forced exhalation. Therefore, a resistance abnormality affects expiration far more than inspiration. See Chapter 20. Acute obstructive disease. There are two common obstructive diseases, bronchitis and asthma, that are intermittent and reversible. Between acute episodes, there are few pulmonary function abnormalities, and the patients are essentially symptom free. Bronchitis is inflammation of the mucosal lining of the tracheobronchial tree. This inflammatory reaction has the common factors of increased and abnormal glandular secretion, mucosal hyperemia, and blood vessels congestion. Yeah. And edema, swelling, ciliary dysfunction, and disruption of the continuity of the mucous blanket. Recurrent or consistent bronchitis leads to chronic changes in the pulmonary mucosa. Bronchitis is caused by such major factors as 1. Smoking and air pollution. 2. Inhalant allergens. 3. Infections. Asthma is an acute onset of muscle spasms in the tracheobronchial tree. The smooth muscle linings of the bronchi and bronchioles contract and result in a narrowing of the lumina. The acute bronchospasm is usually quite amenable to pharmacologic treatment. There is also a glandular component to the asthmatic condition in which very thick copious secretions are produced in the tracheobronchial tree. These tenacious secretions play an important pathophysiologic role in asthma. The treatment of acute obstructive disease is essentially based on sound internal medicine principles. Appropriate pharmacologic and anti-allergic methods of therapy are the hallmarks of good care. It is rare for acute obstructive disease to result in acute respiratory failure. Occasionally, infants will manifest respiratory insufficiency with bronchiolitis. Rarely, the asthmatic patient presents in acute respiratory failure status, asthmaticus. See Chapter 34. Thank you for the likes and subs. Thank you so much. We're pushing towards 600 on this peaceful part of YouTube where we read books and learn. So thank you so much for being here and reading with us because you get to see it live. I put all of these into playlists so people can read the books for the next generation and the generation of now, of nurses and aspiring health and respiratory technicians and providers, healthcare providers. So it's a service. Thank you so much for being here. Thank you so much. I love you. Lord. Mhm. Defining COPD in respiratory care. The exact definition of COPD and identification of the patient population are controversial at best. However, it is essential to develop a clear definition of the entity referred to as chronic obstructive pulmonary disease, at least as it pertains to respiratory care. The word chronic denotes an ever present and continuing disease entity. There are two major irreversible degenerative pulmonary processes in COPD. One, chronic bronchitis, and two, emphysema. Chronic bronchitis. Chronic bronchitis has been arbitrarily defined as cough, with sputum production during at least 3 months of the year for at least 2 consecutive years. Anatomically, it is a disease of the airways, primarily mucosal hypertrophy, inflammation, and excessive abnormal mucus production. There are numerous areas where the cilia are absent. Therefore, not only is the mucus abnormal, but the basic transport mechanism, ciliary action, for the mucus blanket is non continuous, skips areas. Effective bronchial hygiene is permanently impaired and becomes dependent upon routine use of the cough mechanism, which would mean a lot of spontaneous coughing, right? We would witness this. We see, wow, they are coughing a lot. The frequency has upped. Um, Emphysema. Emphysema is a non reversible pulmonary disease causing an obstructive pathology. It is characterized by destruction of the interalveolar septal walls and destruction of the connective tissue responsible for much of the elastic recoil of the lung, resulting in large alveolar sacs that have little elastic recoil properties, right? So it wouldn't be elastic. That means it's a more non-compliant or hardened lung, right? All right. The resultant increase in residual volume is accompanied by small airway changes leading to increased airway resistance. The distribution of these pathologic features throughout the lung has led to various anatomic descriptions, e.g., centralobular or panlobular emphysema. These variances will undoubtedly hold more clinical significance as we learn more about the disease's etiology. Emphysema is an irreversible process and therefore is a chronic disease. All right, COPD. Peace, peace, you too. I wanted to come on here, make sure I bring you some more peace reading. We're almost complete with this book. Yeah, we are in the 32nd chapter. Chronic obstructive pulmonary disease of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, Yearbook Medical Publishers, 1979. And what we have here is a 34 chapter masterpiece on respiratory care that we're reading. We're in the 32nd chapter. So that shows you how close we are. We're doing it. All right. COPD figure 32-1. Thank you for being here. Chronic obstructive pulmonary disease is a progressive, irreversible, and degenerative process that in respiratory care may be considered a combination of five different disease entities. 1. Emphysema. 2. Bronchitis. 3. Asthma. 4. Failure of the right heart. And 5. Failure of the left heart. Patients may have any combination of the 5 entities. A lifelong asthmatic patient may gradually become a COPD patient with a predominant bronchospastic component. The dramatic relief obtained from bronchodilators steadily diminishes as the emphysematous component becomes dominant. Emphysematous change is believed the universal entity in COPD, but very severe cases almost always involve chronic bronchitis and cardiac malfunction. The classic pink puffer is a primarily emphysematous patient. He may have or she may have some element of chronic left heart failure and some bronchospasm, but basically little pulmonary vascular abnormality. Wow. Degenerative and fibrotic pervascular perivascular changes lead to increased pulmonary vascular resistance and eventually comprise right ventricular function. Yeah. This is commonly referred to as a cor pulmonale or cor pulmonale, monale, right heart failure secondary to pulmonary disease. The blue bloater is primarily the chronic bronchitic with severe cor pulmonale and right heart failure. All right, so this is figure 32.1. All right, comparison of the normal lung capacity and lung volumes with classic COPD. RV equals residual volume, ERV equals expiratory reserve volume, VT equals tidal volume, IRV equals inspiratory reserve volume, VC equals vital capacity, and FRC equals functional residual capacity. As you'll see with the COPD, how much smaller the RV, the residual volume is. Okay, here we go. 32.1 of clinical application of respiratory care. All right, there we go. As you see, in the normal, it's distributed more evenly. In the COPD, it's not. The pathophysiology of COPD may eventually result in a failure to meet the body's oxygen requirements. In this event, the cardiovascular system compensates by increasing cardiac output. Eventually, the myocardial reserves will be exceeded and left heart failure ensues. This chapter is devoted to the principles of respiratory care as applied to the patient with COPD. Thus, our definition and classification are functional ones based on the pathologies and pathophysiologies amenable to support and treatment with respiratory therapy modalities. Appropriate medical care and support are assumed. For our purpose, for our purposes, COPD may be defined as a progressive, irreversible, and degenerative obstructive process involving 1. Impaired lung clearance because of decreased ciliary and mucus blanket function. 2. Chronic bronchial inflammation. 3. Inflammatory airway obstruction secondary to edema and cellular infiltration. 4. weakened bronchiolar walls and disrupted alveoli. And 5, collapsed small airways on forced expiration. These entities lead to increased airflow, resistance on expiration, and an increased total lung capacity, primarily caused by an increased residual volume. All right. Thank you so much. Hi, it's hard love. I know it's a lot. I'll put the vocabulary in the description. And, we're going to break it down because we're in the last part of this book. So this chapter is a little bit longer. We'll break this one down into 3 reads. And and then go into the 33rd chapter. So let's finish out page 474 and 475 today. I'm going to let you go on your way. Divine rising. Eyes, heart, love. Diagnosis of chronic obstructive pulmonary disease. Diagnosis of severe chronic obstructive pulmonary disease is made by medical history, physical examination, and laboratory studies. Medical history may include an early complaint of cough and sputum production or intermittent wheezing episodes. Significant cigarette smoking over a reasonable period of time is a common finding. Limitation of normal activity attributable to shortness of breath is usually present. The patient may attribute the start of this problem to a specific event, e.g., pneumonia 3 years ago. However, careful questioning usually reveals an insidious onset of symptoms prior to that event. Bronchitis is specifically delineated by categorization of cough and sputum production. Physical examination may reveal an increase in anterior-posterior chest diameter. This is not as common as previously believed. Mm. Bounded shoulder posture is almost always found, and there is some use of accessory and intercostal muscles. The chest is tympanic to percussion, and the diaphragm has diminished excursion. Ventilatory rate is rapid along with rapid pulse rate. Breath sounds are distant, and wheezes are usually heard during forced expiration. Pulmonary function studies document the existence of COPD. Increased total lung capacity and functional residual capacity result primarily from an increased residual volume. Timed expiratory flow rates are decreased. Chest X-ray will usually reveal flattened diaphragms, hyperlucid lung fields, and increased vascular markings. Mm. Arterial blood gas analysis is seldom involved in the diagnosis, but may aid in evaluating the physiologic severity. External respiration in COPD. Bottom of page 474. An increased functional residual capacity means a constant state of hyperinflation, which decreases the efficiency of air exchange at the alveolar level. The result is decreased alveolar oxygen tensions, responsive hypoxemia shunt effect, see chapter 4, and potentially increased alveolar carbon dioxide tensions. Degenerative alveolar changes, emphysema, result in a diminished area for exchange between alveolar air and pulmonary blood, thus a greater position or portion of the alveolar gas does not exchange with blood. This wasted ventilation is termed dead space ventilation. Ding! The dead space ventilation. Very, very key. because of this next sentence. Increased dead space ventilation requires increased work of breathing. Bronchitic, asthmatic, and emphysematous pathology lead to uneven distribution of ventilation. This creates hypoventilated areas in relation to blood flow, which results in less than optimal oxygenation of the blood perfusing that area of lung. This shunt effect leads to arterial hypoxemia, which causes the cardiopulmonary system to increase work in order to meet the organism's metabolic demands. Increased work of breathing, decreased efficiency in the distribution of ventilation, and decreased efficiency in the distribution of pulmonary perfusion eventually lead to chronic hypoxemia. And we'll pause right here in chapter 32. Wow, it's episode 77. Wow. It's hard love. Did it. Right? When we reconvene, chapter 32, it will be one more after that, and then we'll close out this chapter. Chapter 33 will come after that. I want to thank you so much. Highest heart, love, and honor. Thank you for being here and reading with us. Divine Risings, happy Friday. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Man, look how far we have come. We are really doing it. So proud of us. I knew we could. I told you that's why I come on here to do these readings and stuff and give this information. And also to show you, next generation, you can do it. You have to get in the habit of saying, you know what, I can do it. Instead of saying, I don't know if I can do it. Things like that. We want to shine the light, right? And shining the light is saying, this is what I'm going to focus on, right? When you can do that, we learn the principles of healing sound through pitch, the principle of pitch. Focused energy vibrates the highest. So we want to focus on saying, I can do this. You know what? I have the ability. I can do this. Right? Focusing on the good and great in us. Highest heart love. Happy Friday. Love to all our friends and family. We're shaking it up on YouTube, reading these books, right? Taking it to another level. Mic'd up. You know, that's why I come on here. Make sure I give you this piece because we have to be our soul controller. We have to take accountability for the world that we create around us, right? I have so much abundance. I am full of abundance, love, and honor. Say it to ourselves, right? Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Yeah, slow that in, slow it in. Oh man, look at this beautiful red sage. Isn't that gorgeous? I am abundant. I am so loved, so grateful and thankful for all I have now and all that is coming to me. I love you so much. All I want to say is that I love you so much. Let's have a glass of love water. We're doing it. Almost complete another book. Yeah. So I will put the vocabulary in the description. I wish you have a wonderful day. We're breathing in this nice drizzle of rain that we're getting right now as our elders have, some of them have completed their 40 days and 40 nights traveling through distant land. So we honor you. Baba Uru, highest heart love. Thank you for all you have done, all you are. D'Angelo, thank you so much. Earth Angels, highest heart love. I love you. Ooh. Oh, I love you. I love you. I love you. Wow. Amazing. Amazing. Thank you so much. So grateful. Had beautiful, beautiful. Your healing sessions the last 2 days. I've been busy. We did the grocery giveaway Wednesday. And then Philip Lambert, highest heart love. Thank you so much. Wonderful year healing session. Yes. So we're moving up. We're blowing up. We're starting to blow up. Live from the light here in LA. Thank you so much, Malako. I will see you soon. All right. I love you. I love you. You. You know it. Because I love myself. Have a wonderful day. I'll see you soon.